To begin, let us acknowledge that Queen's University is situated on traditional Anishinaabe and Haudenosaunee territory. We are grateful to be able to live, learn, and play on these lands. We thank the Indigenous peoples of this area for their care of this land for thousands of years, and we hope to honor and respect them as we hold our virtual event today. I'd also like to take a moment to personally thank everybody for joining our presentation today. Our speaker this afternoon is Dr. Richard Horowitz, who will be presenting on the future of Lyme, tick-borne disease, and global health challenges in the 21st century. Dr. Horowitz is a board-certified internist and medical director of the Hudson Valley Healing Arts Center, an integrative medical center specializing in the treatment of Lyme and other tick-borne diseases. He has treated over 13,000 Lyme and tick-borne disease patients in the last 30 years and is one of the founding members and past president-elect of the International Lyme and Associated Diseases Society. Dr. Horowitz has published multiple peer-reviewed articles on effective diagnostic and treatment options for Lyme and co-infection, and has served as a member of the HSS Tick-borne disease working group between 2017 and 2018. He was also co-chair of the HHS Tick-borne co-infection subcommittee, which gave recommendation to Congress on the prevention, diagnosis, and treatment of tick-borne illness. And he was recently elected to the NYS Department of Health Tick-borne disease working group. For dedicating his life to helping those stricken with this devastating illness, he has been awarded the Humanitarian of the Year Award by the Turn the Corner Foundation and awards from Project Lyme. Dr. Horowitz has also published the first peer-reviewed article in the world literature on the role of glutathione deficiency in COVID-19, which has now been cited over 150 times, and he is the author of 2 best-selling books on Lyme disease, Why Can't I Get Better? And How Can I Get Better? He has also now released his first science fiction climate change novel, Starseed Revolution: The Awakening, which contains innovative scientific solutions for climate change. We will have Dr. Horowitz present, and then we will open questions from the audience. You can ask questions by entering your questions in the chat box, raising your hand using the icon, or if time allows, unmuting, asking questions when the time comes up. Please help us welcome Dr. Horowitz to the podium.
Thank you so much. Bonjour tout le monde. Donc, c'est un grand plaisir d'être ici aujourd'hui. I'm not going to do this in French, don't worry. I just wanted to thank everyone for being here today, listening to this presentation. And I've got some exciting news for you today about some new novel regimens for Lyme, one of which I just put into the scientific literature just last week. It still needs to go through peer review, but I will show you the article that we just published or hope to publish, which is, I think, very exciting for the Lyme community because it's a very short-term oral antibiotic course, and it highlights the role of these persisterin biofilm forms in Borrelia burgdorferi. So let me share with you my screen. Okay, great. Let me just make sure this works. Let me put this on. I need to do this just a little bit differently. Hold on. It's better if I do it this way. Okay, great. So I'm going to be discussing with you today some updates on the diagnosis and treatment of Lyme disease. And then the second half of the talk will be about how climate change is affecting tick-borne disorders, what the global health challenges will be. I think in Canada, you've already seen some of this. Just the year before, you had a massive fish kill when you had your temperatures, which soared. I think it was 115, 118 degrees Fahrenheit, where there was like 1 billion fish that got killed in the rivers there. They're seeing the same thing in Australia. We're really kind of in the middle of a very interesting time in humanity's future. So I hope to go through with you today some of the challenges, but also the solutions, that there are solutions, and we've just got a small time period now to start instituting them. So I have some disclaimers and conflicts of interest. As you heard, I have 2 books on Lyme disease. Why can I get better? How can I get better? 2 months ago, I just put out my first book on the climate, Starseed Revolution: The Awakening. I'm on the Zymogen Board of Advisors. I've received grants from Bay Area Lyme and the MSIDS Research Foundation. And the views expressed today do not represent the views of the Tick-borne disease working group, either the HHS or the New York State Department of Health working group, HHS, or the United States. So just quickly, one thing I just want to share with you about practice gaps, because I'm not going to spend a lot of time on COVID. I did put in the world literature the first article on glutathione deficiency, and we've now treated about 130 people with high-dose glutathione and a whole bunch of other nutraceuticals for COVID-19. If you want to see the protocol, it's on my website, www.cangetbetter.com. Just go under the COVID tab. But the reason it's important in this day and age to know about this is because Lyme and tick-borne diseases, not only are they underdosed and misdiagnosed, as we'll talk about, but they overlap COVID-19 in both the acute and the chronic phase. So we might see fevers, chills, fatigue, headaches, cognitive issues, psychiatric issues, muscle pain, joint pain, chest pain, shortness of breath, diarrhea. You need to do a differential diagnosis because these both can be symptoms of COVID and Lyme. So the difference is essentially as with acute COVID, early on, you can get anosmia and dysgeusia where you lose your sense of smell or taste, although this is not so much with Omicron, but more with the Delta virus. If you do get multisystemic inflammation, it's certainly much more than you generally see with Lyme, as you'll see with the lung tissue. So there's a lot of inflammation. But the difference, one way from a clinician can make the differential, is that the Lyme symptoms tend to come and go with good and bad days. And the hallmark of Lyme is that we have migratory pain, migratory muscle pain, migratory joint pain, and migratory nerve pain, tingling, numbness, burning, stabbing sensations, which move around. We've seen that in about 95% of our Lyme patients. We published this in one of the articles that I'll show you shortly when we validated the Horowitz MSIDS questionnaire. So keep in mind that if someone says to you, I feel better or worse with antibiotics, of course, they could have a COVID pneumonia and feel better for that reason too, or have another infection. But generally, if it's good and bad days coming and going with migratory aspects being better with antibiotics, you're probably dealing with a case of Lyme. Although, of course, in this day and age, you can have Lyme disease and get COVID on top of it. So, and in fact, this is the case with many of my patients. So the highlights of the talk I'm going to share with you today is really some of the most important things I've learned in the last 7 years on the importance of biofilm and persister forms of Borrelia burgdorferi. You know, we've been searching for answers for this disease now for over 30 years, and we're coming very close to a durable cure in my practice, and I'll show you exactly why this has been the case. Biofilms have been known to play a role in persistence of multiple bacterial infections, not just, of course, with Lyme. You'll see it in endocarditis. You'll see it in salmonella infections in the gut, candida infections, whether you have a prosthesis with joint. So we know that biofilms can play a role even in your teeth. If you don't go to the dentist and get the biofilms taken off, you can get gingivitis. And they've now even shown that Porphyromonas gingivalis is showing up in Alzheimer's plaques under biofilms. So these biofilms are very important in human health. And we published our first study on dapsone combination therapy 6 years ago. At the time when I published it, this was shortly after Johns Hopkins University had discussed that Lyme is a persister bacteria. And although those of us in the Lyme community knew that Lyme persisted in the body, and of course there are medical political issues with this, but anyone who's been doing this as long as I have, there's absolutely no doubt if you know the scientific literature and you've seen patients, this is a chronic persistent infection, just like Babesia is a chronic persistent parasitic infection, and just like Bartonella is a chronic persistent intracellular bacterial infection. So when I published the study, I did it because we knew that rifampin and dapsone was useful for leprosy. So what I did is I added doxycycline to rifampin and dapsone, figuring it worked for other persister bacteria like Mycobacterium leprae. And later on, we did studies looking at different dosing of dapsone combination therapy. And that's essentially what I'm going to show you today. In fact, the newest study that we just put into the literature about 10 days ago. Study on double dose dapsone combination therapy. And initially, the studies on dapsone were 100 milligrams per day. The study that we published about 1.5 years ago was 100 milligrams of dapsone twice a day. And we found that this 8-week oral generic antibiotic protocol was efficacious for those suffering from chronic Lyme and PTLDS with roughly a 50% efficacy. So what that means is that people who are sick for 5 years, 10 years, 20 years, 30 years, as long as all of the 16-point MSIDS variables that we'll talk about today have been addressed, like you have POTS dysautonomia, you have low blood pressure, you stand up, you get dizzy, you get fatigue, brain fog, anxiety, palpitations. These are all symptoms of POTS. right? Or you might have gastroparesis or difficulty moving your bowels or bladder because the vagus nerve is being affected. You need all the MSIDS variables dealt with properly: low adrenal function, POTS, mitochondrial dysfunction, getting people to sleep, dealing with mold and heavy metals. We'll talk about this, but if you've done your homework and you've taken care of all of these 16 variables, the double dose dapsone will put you into remission with about a 50-50 chance with only 8 weeks of oral antibiotics. However, the 50% that did not respond to this protocol, or responded, they had a positive response, but relapsed, they had chronic Babesia and Bartonella. So the first thing we do when people come into our office is we see they take the Lyme questionnaire that we validated back about 5 years ago with the University of New Paltz researchers, Dr. Mariella Cetera, Dr. Phyllis Freeman. And we put this in the International Journal of General Medicine. This was published back in 2017. It's the first validated Lyme symptom questionnaire in the medical literature. So we know that the Lyme tests are unreliable. Just one thing you should know about this questionnaire is that if you score on this questionnaire greater than 63, you are 2 standard deviations above the mean. You have a very high probability of having Lyme disease. If the score is between 45 and 62, it's probable Lyme, 25 to 44 possible Lyme, and healthy individuals scored below 24. Question 1 on the questionnaire is, do you have day sweats, night sweats, chills, fevers? Question 22, do you have unexplained cough or shortness of breath, air hunger? Those are questions that are significant because they reflect whether someone might have babesiosis. So we find that when we use this questionnaire, we generally have a pretty good sense, especially because migratory pain, right, is the hallmark of Lyme. And there's only 7 diseases in medicine that cause migratory pain. That would include things like lupus, acute rheumatoid arthritis, Crohn's, inflammatory bowel disease, gonococcal arthritis, Reiter syndrome, hepatitis. There's not a lot of things that actually cause migratory pain. So if you had any of those 5 factors, fatigue, flu-like symptoms, joint pain and stiffness, tingling, which is neuropathy, and the memory concentration problems, scoring high, very good chance you have Lyme. And then we look and we do an immunoblot from a lab like IGeneX, which uses 8 different strains of Borrelia. And if you have any one of the 5 bands that are significant for exposure to Borrelia burgdorferi, and I call this game Lyme bingo: 23 outer surface protein C, 31 outer surface protein A, 34 outer surface protein B, 39, and the 83/93. Any one of those bands on an immunoblot, right? Not a Western blot where the 31 band can overlap Epstein-Barr or viruses or autoimmune. I'm talking an immunoblot. Any one of those bands with a high score on the questionnaire tells you you have been exposed to a Borrelia species. And after seeing 13,000 Lyme patients, I tell you absolutely this works. There's not a question about it. When you're looking at how to get a Lyme patient better, one way of thinking about these 16-point MSIDS variables that I published in both of my books, and again, the last book, How Can I Get Better, is probably a more up-to-date version for those of you who've not read it, because one of the chapters is on dapsone combination therapy. We think of this in terms of Lyme patients. Why are they sick? Well, they're sick because they have inflammation. Same reason why someone is sick from COVID. And this can be from multiple biochemical pathways that are being stimulated. NF-kappa B, right? You all of a sudden start producing TNF alpha, IL-1 beta, interleukin 1, interleukin 2, IL-6, IL-8, IL-10, IL-17. All of these inflammatory cytokines and chemo, CXCL10, CCL17, they're all produced and they cause fatigue, headaches, brain fog, memory problems, joint pain. So when you think of it in terms of inflammation, and these are the same cytokines, by the way, that are produced in COVID, which is why when we block NF-kappa B with NAC, alpha-lipoic acid, and glutathione, or we stimulate NRF2 using curcumin, turmeric, broccoli seed extract, sulforaphane glucosinolate, or we block NLRP3 inflammasomes with melatonin. These are the same things we do in Lyme patients. We do it in COVID. It generally tamps down that inflammatory response. And we have not lost, by the way, one patient. Not one patient in my practice died from COVID in the last 2.5 years using the protocol that you'll find on cangetbetter.com under the COVID tab. But when we're thinking about why Lyme patients are sick, number one, chronic infections, the 3 top ones that we generally think of is Lyme, Borrelia burgdorferi. We then follow up with Babesia. and Bartonella. Now, you could have Mycoplasma species, you can have tularemia. There are a lot of other infections that can persist, including viruses like Epstein-Barr, herpes virus 6, CMV. But the bacteria are basically the ones that are keeping most of the people ill. We then look at the dysbiosis of intestinal bacteria in certain people because we found that, and they're finding this, of course, with Alzheimer's, Parkinson's disease, autoimmune illness, MS, that apart from viruses like EBV now that they've associated with MS, they're now finding that certain bacteria in the colon are now also being associated with some of these inflammatory illnesses. We find a lot of leaky gut and food allergies and mast cell activation in this population. So the reason it's important is because if you're eating the wrong foods that you're allergic to or sensitive to, and you have mast cell disorder, you can generally start screening it, looking at tryptase, chromogranin A, and histamine levels in the blood. You get the same inflammatory cytokines from leaky gut that you're going to get from Lyme. So it's rivers of inflammation going into a large ocean. You got to figure out where all the inflammation is coming from. We know that Lyme patients don't sleep. If you don't get to sleep, your IL-6, your interleukin-6 levels are high. Again, you're going to feel ill. Then we get a lot of environmental toxins showing up in Lyme patients like heavy metals and mold. Mold is showing up in about 75 or 80% of my patients. And one of those mold toxins, gliotoxins, is immunosuppressive. So if you've not checked the Lyme patients for immunoglobulin deficiencies and subclass deficiencies, in the study that we published that I'll show you in just a second, we found that about 85% of our patients had one or several subclass deficiencies, specifically subclass 1 and 3. When you get acute Lyme, it goes up, but in chronic Lyme, subclass 1 and 3 goes down, and you need them for phagocytosis and helping to get rid of the bacteria. And some of these people, up to 7%, had chronic variable immune deficiency, up to 20% had low IgG levels. If you have low immunoglobulins or subclasses, you're not going to fight the infections properly. And then you've got mold toxins, or you might have anaplasma exposure, which affects also your immunity. All of these things are going to interfere with getting over Lyme. And finally, you might have nutritional deficiencies from all these environmental toxins getting in, where your magnesium, copper, zinc, iodine levels are low. And just one example with zinc, if your zinc levels are low, you're going to get a lot of inflammatory cytokine production. So you've got to look at all the sources of where inflammation is coming from, because inflammation is what causes symptoms in both COVID and in Lyme. And then you have to look at the downstream effects of the inflammation. We're seeing a lot of low testosterone in men. 95% of my patients have low adrenal function on a DHEA salivary test. Neurological, psychological dysfunction. About 40–50% will have POTS dysautonomia, like in COVID-19 and long haulers. Mitochondrial dysfunction, also seen in long haulers. Pain syndromes, liver dysfunction, and finally, autoimmune phenomenon. Again, autoimmunity, same thing we're seeing in patients who have COVID-19 who have long haul. So if you haven't read these two studies on the Precision Medicine 1, these 200 patients who did dapsone combination therapy, and Precision Medicine 2, the role of the MSIDS model in defining, diagnosing and treating chronic Lyme PTLDS, these are important works that we put in the literature several years ago because it really gives you a pretty good overview of what we're seeing in our practice and how we're getting patients better. And when we look at the percentage of patients with these MSIDS abnormalities that I was just discussing with you, you'll see that the majority of them have, at least 70% of the patients have multiple MSIDS abnormalities overlapping why they stay ill. So keep in mind, if you're a Lyme patient and you're not well, you've got to go after these 16 variables to figure out why you're not well. And by the way, we're looking now at these same 16 variables and glutathione deficiency in a randomized controlled trial for long haulers at the University of California, Irvine. And we're hoping that this will start soon. I'm waiting for the FDA to give me an IND, an investigation and do drug application for glutathione because we're finding it to be very effective in this population of patients. So why do patients get sick from Lyme? Well, we know the tests lack adequate sensitivity. If you're just using a standard ELISA followed by a Western blot, it's going to miss about 50% of the patients. That's well established in the medical literature. And you get improper diagnosis. Many of these patients coming in have been diagnosed with chronic fatigue, myalgic encephalomyelitis, fibromyalgia, some form of an autoimmune disorder like rheumatoid arthritis, lupus or MS. And MS is a particularly difficult one because the symptoms can overlap and you can get white spots on MRIs. The difference is if you do an MRI of the spine, however, you're not generally going to see demyelination. That's only generally going to be an MS. and finally, neuropsychiatric disease with dementia. So this is especially true for the multiple Borrelia and Bartonella species that are out there. But we know that Borrelia can persist. And these persisters, as we talked about, can be not just for Lyme, but for other intracellular bacteria, specifically Bartonella, Mycoplasma, Tularemia, even Brucella. So we will run a large tick-borne panel and check for a lot of these infections when patients first come to see us. And of course, the reason we've gone so long and why people don't really know about this has more to do with healthcare politics than medicine. The healthcare politics, at least in the US, and I know in Canada, you're suffering from some of the same because I followed your politics over the last couple of years. There are problems with diagnostics and persistence, and yet some of your committees in the government are basically denying that this is the case. They're following some of the IDSA guidelines. And unfortunately, the IDSA guidelines do not work for patients who have chronic Lyme disease, PTLDS. They basically don't have an answer for this population of patients, but I do. And I'm going to show you the answers today in peer-reviewed studies. And again, this latest study that I think is probably the most exciting one that I've ever put into the literature. So if you want to look at some of the treatment failures for Lyme and what's been published in the medical literature previously, we know that Lyme persists in the skin and the fibroblasts, in the eyes, in the ligaments, in the joints, in the endothelial cells and macrophages. And that's, I think, where a lot of them hide that dapsone combination therapy is going after, because this is an intracellular protocol. It can go up into the central nervous system even within 24 hours of an infection. And then in the last couple of years, we started discovering that you've got these persister forms, these dormant biofilm forms that basically reactivate once you stop your antibiotics. In the past, we thought it were what were called cystic forms or cell wall deficient forms, also called L forms, S form, round body forms, right? That's what they look like under the microscope. But then we realized in the last couple of years where most of the inflammation is coming from is from these persister forms and biofilms. So when we did our study on dapsone combination therapy, and we looked at 200 people who had done the study, and at this point, this was 100 milligrams of dapsone, 14.5% of those patients were PCR positive for Borrelia burgdorferi, despite years of antibiotic therapies prior to this protocol. Babesia was persisting by both PCR and fish, fluorescent in situ hybridization. They had taken things like atovaquone and azithromycin, clindamycin, and quinine, still active. We know that Babesia right now does persist. It's a very difficult parasite to get rid of. We're looking at the phenequin studies right now in our practice. Bartonella henselae was persisting, or other Bartonella species, by PCR and by fish. We would see tularemia reactivate with a 4-fold increase in titers, brucella that would turn positive by agglutination, mycoplasma species like fermentans or penetrans that would be positive. These are intracellular pathogens that survived single or double intracellular antibiotics. And then occasionally we would see reactivation of viruses like herpes virus 6 by titers or PCR, or Epstein-Barr virus. So these biofilms are protecting the bacteria. Eva Shapi had done studies at the University of New Haven years ago and discovered that these biofilm formations was one of the reasons that Lyme was able to persist in the body. And there was an article that was published about a week ago by Monica Embers about antimicrobial tolerant persistence in Lyme disease. So if you have not had a chance to look at this, this was just released about a week ago by Dr. Embers, who's now serving on the HHS committee. So Hopkins years ago showed that these stationary phase persisters and biofilms is where most of the inflammation is coming from. And this is really an important understanding in treating patients for Lyme disease, because a lot of patients out there are still using IV drugs like Rocephin. They're using Ceftin and cell wall drugs and Flagyl for treating Lyme. And I can tell you, not effective. But it's not going to be an answer for anyone who has suffered with chronic Lyme who has this for more than research notes on the effect of dapsone with intracellular antibiotics against the Burgdorferi. And University of New Haven lab, if you look at the upper left corner with dapsone, you'll see that dapsone alone had a better effect on the biofilm forms than just using doxycycline, right? You can see those green dots are much smaller. If you go down to the bottom to the right and you look at K, dapsone doxyrifampin, notice that you can barely see the biofilm form at all after 72 hours of treatment. And if you go over one to the right to L, when you add azithromycin, doxy with dapsone was more effective than dapsone. Doxyrifampin dapsone was better than 2 drugs. And if you did doxyrifampin, zithro, and dapsone, that had the most significant effect on reducing the mass and viability, as well as the protective mucopolysaccharide layer of Brie-Burgdorferi biofilm. So these findings might explain, at least in part, the clinical efficacy that we've seen in the dapsone combination trials. We then followed it up and published a study in the journal Antibiotics. This is again about 1.5 years ago, efficacy of double dose combination therapy in the treatment of chronic Lyme PTLDS. And what was exciting about this study, and it was a retrospective review of 40 patients, is we found that if you gave a 7 to 8 week oral generic protocol, doxycycline or minnow, rifampin or rifabutin with doxy, just oral generic drugs for 7 or 8 weeks, it was superior to lower dose dapsone. So meaning that the higher doses, 200 milligrams of dapsone, was more effective than 100. And it led to long-term remission in 45% of patients for 1 year or longer, including people that were sick for 20 or 30 years. If you happen to have been a patient who had PTLDS, you had had an EM rash and failed therapy, it put them in long-term remission for 58%. So it was about 50% that went into long-term remission. But again, the problem was the 50% that did not respond was generally due to Babesia or Bartonella that was not properly hit by this protocol. And clearly, we need a multi-center placebo-controlled randomized trial and find effective treatments for Babesia Bart. When you look at that study and you look at Babesia fish, which is over to the right, there were 6 patients that were fish positive. You'll notice 3 went into remission. So you at least had a 50-50 shot if you were active with babesiosis that the regimen would still work. But if you go all the way to the right to Bartonella fish positive, you'll notice there were 7 patients out of 40 that were fish positive, and not one of them went into remission. They may have improved, but they did not remain in remission. The symptoms relapsed once they stopped the drugs. So this is the article that we just put into peer review a little over a week ago. We submitted it to the journal Microorganisms that asked us to submit before the end of April. Efficacy of short-term high-dose pulse dapsone combination therapy in the treatment of chronic Lyme PTLDS and co-infections, 3 cases in literature review. Now, this was 25 patients who did 4-day pulses, right? We're not talking 7, 8 weeks at this point. These patients generally did double-dose dapsone. Several did not, but most did. But we were only using 1 to 3 courses of a 4-day high-dose pulse. What is a high-dose pulse? Instead of 200 milligrams of dapsone, which is what we used for double-dose dapsone, this was 4 days of 400 milligrams of dapsone combination therapy. So the purpose of the study was to evaluate, since double-dose dapsone, 200 worked better than 100, would 400 milligrams work even better? Because when you looked at the biofilm studies that we did, the higher the doses of these persister drugs, the better they seem to work in culture in lowering down these resistant biofilm forms. So we looked to see how well it worked in resistant chronic Lyme PTLDS. And again, these were generally the patients who failed double-dose dapsone combination therapy. So these were 25 patients. They had ongoing symptoms. They had already done 1 or more courses of high-dose pulse dapsone combination therapy, depending on their symptoms. What happened is the majority of the patients noticed sustained improvement. Again, these are 4-day pulses, like once a month, in 8 major Lyme symptoms, including fatigue, pain, headaches, neuropathy, insomnia, cognition, and sweating. And the important part of this article is that it was the dapsone dosage, not just the treatment length, that positively affected outcomes. So high-dose pulse dapsone combination therapy may represent a novel therapeutic approach for the treatment of resistant chronic Lyme PTLDS. This is going to be the randomized controlled trial that I plan on starting hopefully sometime next year. I've been trying to figure out exactly what is the randomized trial I'm looking for, and I'm certain at this point that this is going to be it. We're probably going to do an 8-week double-dose dapsone protocol. The 50% that go into remission, no more treatment is needed when all the MSIDS variables have been addressed. The 50% that do not go into long-term remission, they will receive 1 or several pulses once a month, 4-day pulses of this high-dose dapsone combination therapy. And if you look at this table, which is similar to the table I published about 1.5 years ago, you'll notice if you go over to the right under Bartonella fish, 2 out of 4 people went into remission who were Bartonella fish positive. We didn't have anyone in that last study who went into remission. So you can go on and you can actually read the study. I've got it in preprints right now. It's being reviewed in peer review right now. And when we looked at the MSIDS variables in these 25 patients, it's very similar what we saw in the prior dapsone studies. We would see liver dysfunction and non-alcoholic steatohepatitis, food allergies with leaky gut with mast cell, insomnia, sleep disorders, neuropsychiatric issues, POTS, low testosterone, low adrenal was actually number 1, mitochondrial issues, detoxification problems, mold and heavy metals, autoimmunity, immune dysfunction, viruses with reactivation like Epstein-Barr, Candida, hypoglycemia, and of course, Babesia bartonella. So 21 of 25 patients, 84% showed improvement in their tick-borne symptoms. 1 patient had a temporary worsening post-therapy because of a severe herx, but 32%, almost a third, had a resolution of all active Lyme symptoms post-treatment for 3 months or longer, even if they had active Babesia and Bartonella. So we're only talking 4-day pulses here, which means we have confirmed, at least in my view, we're obviously going to need a randomized trial, but I know my patients well at this point, and these patients who were in the study were the most resistant Lyme patients I have treated in years, and at least a third of them went into long-term remission just by doing these 4-day pulses. 43% who had an EM rash and history of PTLDS remained in remission. 57% showed mild to moderate improvement. And again, the reason this is important is because a lot of doctors are saying, well, we don't even know what PTLDS is. Come on, folks. You got to wake up at this point in time. I've already published this stuff in the literature. I've been publishing for years on this. This is MSIDS. It's the variables. It's these 16 variables keeping people sick, and it's chronic infections like Lyme, Babesia, Bartonella. We don't need to go back 30 years in time and make believe we don't know what is happening here. And I've asked John Hopkins, I spoke to John Alcott, whether he would like to be involved in this because he has one of the largest PTLDS groups. Of course, I've not heard from him, but anyone who has an interest at a university, if you have a Canadian university that will not suck all the money out of the research, because the problem with working with a university, nothing against universities, but I'm doing this now with a randomized trial at University of California, Irvine. The universities take a massive amount of money when you're doing a randomized trial. If you have a Canadian university that wants to be part of this study, so I can move this along in Canada for you, please let me know, because I'm doing a doctor training for healthcare providers the second weekend in August of this year. I will be training physicians and providers in this new protocol with this high-dose dapsone therapy. So everyone who is in the course understands how to do the protocol. They will most likely be the providers that I'm going to get to do this randomized trial. Among the 11 patients who were Babesia fish positive, 27% remained in remission, 6 improved, 2 had no change. And among 19 patients, 76% with a history of BART, 79% improved, 21% had no change in symptoms. Among 8 patients with proof of active BART by PCR or FISH or elevated VEGF, 38% remained in remission. Now, you have to understand that the reason this is such an important paper from my standpoint is that there has never been an oral antibiotic regimen, short course especially, that has ever been published for chronic Bartonella. If you came into a doctor's office with Bartonella endocarditis, you're going to get IV gentamicin and a whole bunch of IV drugs. And IV gentamicin has its own source of issues because of the issues with the ear, with the cranial nerve, where you can get vertigo, even if your peaks and troughs are normal in the blood. You don't want to use gentamicin if you don't have to for a chronic Bartonella infection. This is the first regimen that will ever be published, hopefully, and it hopefully will get this through peer review in the next month, that shows that it has some potential, at least, follow them long-term. But at least 2 out of 4 patients who were BART fish positive went into remission, which I did not have any remissions when I was doing the double dose dapsone for BART. So the largest symptom improvement in this cohort was cognition, 68%, joint and muscle pain, 64%, fatigue, 60%. Those are always the top 3 symptoms, right, in chronic Lyme. Headaches, 36%, neuropathy, 20%, insomnia, sweats, chills, and flushing, which is, of course, babesiosis. Palpitations, a couple of patients with tinnitus got better, although one of them had overlapping mercury toxicity who's being chelated. Mercury also will cause tinnitus along with Lyme. Dyspnea, and interesting, some of the patients described this as peeling an onion. They did one course of 4 days of high-dose dapsone. And in the first round, they might have had, for example, visual snow, like, hey, doc, I can't see well. No other protocol you ever gave me in years worked. And all of a sudden, I did a 4-day pulse and my vision's better. And then a month later, they do another 4-day pulse. Hey, doc, my neuropathy, which has been problematic for years, all of a sudden, my neuropathy's better. They do another pulse another month later. All of a sudden, their fatigue is better, literally like peeling an onion. Now, again, we're going to need much larger groups of patients. This is 25 patients I'm reporting on, but they were the most resistant patients in my practice. So the conclusion for future studies is that 200 milligrams of dapsone is more effective than single dose, 100 milligram. And these 400 milligram pulses for 4 days are more effective in certain chronic Lyme PTLD patients. And when you read the article, you'll see how I controlled methemoglobin by using higher doses of methylene blue, higher doses of glutathione. We're now using things, antioxidants like vitamin C, vitamin E. I'm adding cimetidine tagamet, which has an effect on methemoglobinemia. And we're also using Inada NADH, as well as even some supplemental oxygen if people need it. So we can control the side effects of these 4-day pulses by using antioxidants and methylene blue. People just have to get off their psychiatric drugs to avoid serotonin syndrome, and they have to get off certain foods to make sure that they don't deal with an MAO type event where they may get a hypertensive crisis. But this is all in the article. If you read it, everything you need to do in the protocol is there. So the importance of this is what they found in disulfiram. And by the way, some of these patients who did this had done disulfiram, another persister drug that came out of research out of Stanford. They did disulfiram and dapsone together. And one of the patients in the study who did better with disulfiram than dapsone, but couldn't go into long-term remission, she did one 4-day course off disulfiram because she still had symptoms and went into remission. So there may be a way of working with several persister drugs, and we don't ever go past 250 milligrams of disulfiram at this point to keep down the side effects, because the higher dose of disulfiram in the Liegner studies that he published were more effective in remission, but it had more side effects, psychiatric, fatigue, neuropathy. Not the case with dapsone. Dapsone actually helps neuropathy and it helps neuropsychiatric effects. So it's very hopeful for the Lyme disease community. So the randomized trial that I'm going to look at is 8 weeks of double dose dapsone and then several pulses of this high dose dapsone combination therapy. So I'd like to finish up the talk with you about climate change and ticks and some of the global health concerns that we're going to be facing. We now know with the climate that ticks are coming out 3 weeks earlier. This comes from the Institute of Ecosystem Studies in Millbrook, New York. And the higher global temperatures are increasing the reproductive rates of insects, ticks, mosquitoes, and fleas. And that's why last year in the United States, we had about 500,000 new cases of Lyme in 2021, according to the CDC. Climate change is also increasing environmental toxicity. If you look at what is now in wildfire smoke, it is extremely toxic with all of the plastics and wood products and things that are in the smoke. It also contains a small particle pollution, less than 2.5 parts per million, which have been associated with dementia. You get mold exposure from water damaged buildings, from all of the flooding, as well as increase in heat strokes, right? This happened in Canada last year. Dehydration, asthma, cardiac events, respiratory events. They're even finding after the wildfires, if you look at the type of ticks, they found in one study that the ticks pre-fire were Ixodes ticks, and after the wildfire, they were roughly 55% Ixodes and 45% dermatocenter, which means you're now going to get rickettsial infections like Rocky Mountain spotted fever, which can be deadly if you don't get it within the first 7 days and get on tetracyclines. By the way, one point about that I will make. If you have children that you're treating less than 8 years old, or you're a pregnant woman who gets a tick and it's been determined that there may be rickettsial, Ehrlichia anaplasma exposure, you are allowed to use short courses of doxycycline. It does not stain the teeth and it is not a problem for the fetus. And this comes out of the work I did for HHS and from the work that I work with the CDC. So you do not hold off treating people if you suspect anaplasma, 3% mortality rates, or Ehrlichia, 1% mortality rates, Rocky Mountain spotted fever. You can get your limbs amputated and die from this if you don't get it in within 7 days. And a lot of this has happened to kids because pediatricians were worried about giving tetracyclines. Doxycycline is not a problem for 7 to 10 days. Big take-home point from this talk today. So tick-borne diseases are going to be increasing in the future, as well as mosquito-borne illness. dengue fever, West Nile, because the mosquito population is going up, as well as even BART because of the flea population. We're rapidly running out of time. So the IPCC report, my new book, Starseed Revolution, it came out one day after the last IPCC report came out. This was in the Washington Post, that humanity has a brief and rapidly closing window to avoid a hotter, deadly future. Basically, there will be parts of the planet that become unbearable. You happen to be, by the way, in Canada, in probably one of the best places in the world to be living, because some of the places in Canada that have been cold as hell that nobody would ever want to live in will probably be the next South Carolina, the way we have in the United States, because of the way the climate is changing. But I know that you've already seen some of the problems with massive fish kills and heat strokes and stuff that has already happened in Canada when you had that massive heat wave that happened last summer. So unchecked greenhouse gases are going to raise sea levels several feet. This was not expected to, by the way, to be the case when I started writing the book 4 years ago, when kids were coming in with climate grief. They were coming in with getting over Lyme after doing double-dose Dapsone. And I said, well, what are you going to do with your life? And they said, nothing. I said, what do you mean nothing? I said, you're going to go to college? You're going to get a job? No. I said, well, why not? Well, the world's going to end. Why should I bother going to college and getting a job? And, you know, when the universe starts knocking up my door and these kids are coming in with climate grief day after day, week after week, this was happening years ago. I did a deep dive into the climate literature 4 years ago, and I realized these kids were right. We were in big trouble. So we're going to see more droughts. Right now in the Midwest in the US, we're in horrific conditions right now, with Lake Mead is at the lowest it's ever been. Heat strokes, hunger, we're going to have a problem growing food, millions of climate refugees, loss of animal species, more vector-borne diseases, and deaths from malnutrition, heat, and pollution. So this was just published today. This just came out this morning. It was in The Guardian, that the climate limit of 1.5 degrees is close to being broken, and that the probability in the next 5 years of surpassing the limit is up 50% from 20% in 2020. Now, again, when I wrote this book and started writing it in 2018, this was science fiction. My book starts in the year 2037, when Prince Ian of Arcturus, who's half human, half Arcturian, has come to save the planet. And I described the first great climate change at 1.5 and the next second great climate change at 1.6. I did not expect this absolutely to happen by the year 2037, as it was written in the book. It now looks like, since I started writing it, that we may actually hit it. So what is the overview, and why is it urgent in the next several years that we need to address this? Well, we've got these new infections, mosquito, tick-borne fleas, pollution, as we talked about, wildfire smoke, mold toxins from water-damaged buildings, because we're getting a lot of these buildings that are flooding. The rise in global temperatures, more wildfires, droughts, level 5 hurricanes, tornadoes, and sea level rise. And I'm going to talk to you about the Thwaites Glacier in a second, which is the most imminent threat, and why the world governments are not coming together to do geoengineering at this point for this one particular issue. I'll show you in a second. It's beyond me, because we've only got a couple of years before the ice shelf cracks off. And then we're looking at a loss of biodiversity with ecosystem disruption. With pollinators, we're losing the bee populations in the United States. Many of them are now lost in several states. And we're going to see millions of climate refugees looking for food, water, and safety. It's a national security issue. So when I started reading Elizabeth Kolbert's book, The Sixth Extinction, which she received the Pulitzer Prize for, this book, you could ask fiction or speculation. Well, this actually got published this year as in Biological Reviews in 2022, that the biodiversity that's making our world so fascinating is functional, and it's vanishing and unnoticed at an unprecedented rate. So we are in the early stages of a sixth human extinction event. By 2040 to 2050, scientists have determined that 1/4 to 1/3 of all Earth species will be extinct, including bees, pollinators, insects, multiple species of fish from warmer polluted waters, certain mammals, and excess man-made carbon methane pollution is causing melting of the permafrost, because we know now that the Arctic is 2 to 5 times warmer that we're now seeing in North America, which is now 1.2 above pre-industrial levels. Siberia the year before, so the warmest season in 130 years. So these are all now starting to appear in the scientific literature. Accelerated modern human-induced species losses entering the sixth mass extinction, with loss of biodiversity being one of the most critical current environmental problems threatening ecosystems and human well-being. And I'll show you the solutions at the end. We're coming to the end of this talk shortly, where one of the solutions is going to have to be that we preserve 50% of all the lands and oceans on this planet because of this loss of biodiversity. So the records of extinction for reptiles, amphibians, freshwater fishes, and other organisms have been documented since the beginning of the 20th century. And population level extinction is the prelude to species level extinction. The United Nations has now said that extinction rates are rising by a factor of 1,000 above natural rates. We're experiencing the greatest wave of extinction since the dinosaurs. We're up 1,000 times more above natural rates. Every hour, 3 species are disappearing. Every day, 150 species are lost. And every year, 18,000 to 55,000 species are becoming extinct. So again, these are now showing up in the medical literature, article after article, vertebrates on the brink as indicators of annihilation of the 6th mass extinction. And climate change is also hastening the spread, right? Some species are going down and other species are going up. And unfortunately, the species going up happen to be ticks, mosquitoes, and fleas. So since the 1990s, a warmer climate has shortened winters. Lyme's duration is expanding its reach. The higher latitudes and altitudes are poised for dramatic spikes in disease risk. And vectors, tick vectors that spread Lyme, and mosquito vectors for dengue fever, malaria, chikungunya, Zika, West Nile, they're all going to start to go up because the reproductive rates of these insects are tracking the increase in environmental temperatures. We're also going to see an increase in fungal infections like valley fever and the coccidioides. The US policy, I don't know Canadian policy at this point as far as what you're exactly doing, but I can tell you in the US, the present healthcare policy is not stopping the spread of these vector-borne diseases, and they're making these disease-carrying bugs more resistant because they're using chemicals used to fight them that are now causing genetic changes. So vector-borne diseases are currently accounting for more than 17% of all the world's infectious diseases, and we're not looking at a good long-term management strategy of arthropods, which is contributing to resistance. So for example, now we see the Lone Star tick. The Lone Star state is Texas, but the Lone Star ticks is now from Long Island in New York, all the way up to the coast of Maine, going up into Canada. What is in the Lone Star tick? I call it tears as a mnemonic: tularemia, Ehrlichia, alpha-gal, rickettsia, and stari. And nymph bites have been mistaken for chigger bites. My patients have come in from Long Island with this. We're also now seeing Gulf Coast ticks from California showing up in New York City and our boroughs. The risk, Rickettsia parkeri, which is a little bit different than Rocky Mountain spotted fever, but you can still get similar signs and symptoms: fever, headaches, muscle aches, and rashes. Difference is there's an inoculation eschar at the site of tick attachment, but you get the same type of biochemical changes: low white cell counts, low platelets, elevated liver functions. You need to look for a four-fold antibody titers, and again, doxycycline if you suspect it at all. So the UN IPCC report that came out late last year is that human activity is driving our climate emergency. There's no doubt that this is humans that are doing this with greenhouse gases. It's projecting us to hit 4 degrees of warming by the next century if we stay the present course. And the upper end of probability is 8 degrees. The last time the planet was even 4 degrees warmer, just go look at the Dover Cliffs in England, which are several of 100 feet higher. That's where the oceans were years ago. But the reason the world governments need to come together, and if anyone is on the Canadian government at this point who's listening to this talk, please start to connect with me and the US government and all world governments, because what they're now finding, and this is published last year in Nature in December, that there are cracks that are showing up in the ice shelf for the Thwaites Glacier. It's the size of Florida. If this thing drops into the ocean, which they're suspecting in the next 3 to 5 years, it's going to raise global sea levels by a minimum of 2 to 3 feet. That means that New York, Boston, Miami, coastal cities across the planet, whether it's in Europe with Amsterdam or you're looking at Venice, better go visit these places soon if they don't get this one together. You're going to see the Thwaites Glacier start to cause a rapid sea level rise. It's already been built in. So there's only one way, in my opinion, we're going to be able to stop this, and I'll show you this in a second, which is geoengineering. But they're suspecting a potential collapse in the next 3 to 5 years, and spiking methane, which is coming from the melting permafrost. Methane is 80 times more potent than carbon dioxide. We know that the Arctic is 2 to 5 times warmer than we are now in North America. So as the methane is coming out, including nitric oxide, which is 300 times more effective at heating the planet, which is why the agricultural practices need to change to regenerative agriculture. If we don't do this, the last time the Earth had carbon dioxide levels at 420 parts per million, which is where we are now, was during the Pliocene era millions of years ago, when the oceans were 30 to 80 feet higher. Please do not think that this is science fiction. This is what's about to happen in the next several years. We're about to hit some tipping points. We really need to be moving on this thing fast. So the 2-degree centigrade rise will be massive glacial melting in Antarctica, flooding in low-lying areas, destruction of farmland with food shortages, tens of millions of climate refugees. And the hardest hit, by the way, will be your indigenous people. Thank you for saying and giving a thank you to the indigenous people when you started this talk. My book, Starseed Revolution, honors the indigenous peoples. There is a very large part of this book that has a medicine wheel ceremony that includes the indigenous people and the wisdom of the indigenous people of how to help the planet. I know when you read the title of this book, you would not know this. You will see when you read Starseed Revolution, there is a big tip of the hat to the indigenous people and what they have done to actually know how to protect our planet. So the health risks that we're looking at now in the future, heat-related morbidity and mortality, more heat strokes, ozone-related mortality, increasing emphysema, asthma, respiratory problems, mold toxins, small particle pollution from wildfire smoke, malnutrition, decreases in livestock population from less feed and available water, decreased fish number and diversity. The oceans are becoming acidified because the carbon dioxide has nowhere to go except into the ocean, and therefore it's acidifying the oceans. Pollinator populations are going down, and you need proper nutrition for detox and immunity for treating Lyme disease, with all of the risk in vector-borne diseases that we talked about. But one risk you generally don't hear about much, just as we're starting to see Omicron, right, go down. I mean, we've got the variants right now, but they're not quite as severe as Delta, is a risk of new viral infections that are going to come from this melting permafrost with bacterial and fungal diseases. What they've shown is that as the permafrost melts, there are new infections that may be released, triggering another pandemic. So here's some of the articles that have showed up here, and it's because in these millions of years that the ice has been frozen, there's been a lot of bacteria, viruses, and fungus that humanity has never been exposed to that is released. It can go up into the stratosphere at 50, 60,000 feet, and it could be carried to North America. What infections agents have been found in the permafrost? Viable viruses, bacteria, and fungi. They have found hundreds of isolates of bacteria and fungi and viruses from ancient ice and permafrost, and long-distance airborne transport through stratospheric levels can take place. So this may lead to new pandemics, and we have no immunity. And if you think you can keep making messenger RNA vaccines every time you get a new virus coming out, you're never going to be able to catch up with this in time. And then, of course, it's the environmental toxins we're exposed to. Heavy metals, PCBs, right? Forever chemicals that are now showing up in everyone's bodies, that is now being linked up, by the way, to NASH, non-alcoholic steatohepatitis, which is showing up in kids at this point and in adults. Organofluorines and bromines, volatile organic solvents. These are all been linked to not only more free radical oxidative stress, which drives inflammation, which would make a Lyme patient sicker, but endocrine disorders, cancer, ADD, ADHD, autism, ALS, allergies, Alzheimer's, Parkinson's. They've all been linked up at this point to these environmental chemicals that we continue to pump out hundreds to thousands of these chemicals, which are in part due and causing some of this loss of the pollinator populations from the neonicotinoid pesticides. So it's in part a problem with the permafrost, but also a problem with how we're dealing with chemicals. And these infections and toxins are driving inflammation, which is the #1 cause of all acute and chronic disease. So as our healthcare costs go up every year, we need to start thinking about what are the cause of all of these acute and chronic diseases. 70% of chronic diseases in the United States, right, are due basically to looking at this type of an inflammatory response, and 80% of the deaths. So in Starseed Revolution, I have a 3-part program to help transform and protect the world, transforming planetary health through transformation of social, political, medical, economic, and energy structures, transforming personal health through transforming and preventing the 3 I's, infections, immune dysfunction, and inflammation, and transforming the world through quantum physical principles, which I call the 1% global climate solution. So to get the world in balance, and you can go on my website, www.starseed-revolution.com. Just go under the section that says climate solutions, and you can read the 25-page blog that I have on this. But we're going to need to do efficient energy production and storage, geoengineering, changes in agriculture and food production, such as regenerative agriculture, because the way we do agriculture right now, we're depleting the soil, but we're also releasing carbon back into the atmosphere. There has to be regenerative development and an entire change in the economics, which would be donut economics, which comes out of Kate Raworth from the UK, which is a whole new economic system, which includes the earth and the ecosphere in every economic decision that we make. Mark Jacobson from Stanford University published this in the journal One Earth. Wind, water, solar for 139 countries. He has a roadmap to get 139 countries off fossil fuels. It already exists to avoid this 1.5-degree global warming and millions of annual air pollution deaths. So it's not that we don't even have a roadmap to electrify everything with wind, water, solar. We have it. He already published it, and he's in my book. But the geoengineering part, specifically because of the Thwaite Glacier, is the solution like sulfate seeding, which mimics volcanoes, marine cloud brightening, 1 million square miles of solar reflectors, which comes out of Harvard University, and electrifying everything. We have solutions. But in the next few years, if we don't start to integrate this and get governments working, even Antarctica, to work on this to geoengineer the Arctic before the Thwaites collapses, we're going to see a rise in sea levels. And then because of personal health being affected, where inflammation is the #1 cause of all disease, from my perspective, this MSIDS model that I've been using for Lyme is really perfect because you're going from a one cause, one disease model that has been in medicine for years to one where multiple sources of inflammation and downstream effects are affecting people's health. And whether it's Lyme or you're talking about other diseases, these underlying factors are still showing up in the medical literature. Finally, transforming planetary health through quantum physical principles. About 13% of the world population is now suffering from anxiety, depression, and climate grief. Over 300 million individuals suffer from depression. And I also have solutions in the book based on some of the teachings that I've received from studying with my Tibetan teachers for over 40 years of how to work with the mind in a very effective way to transform and bring us to a healthier world. So in conclusion, climate change represents the greatest existential threat to humanity's survival because of changes in the ecosphere with biodiversity loss. Multiple health risks exist from wildfire, heat strokes, drought, flooding, hurricanes, tornadoes, and more tick-borne diseases with environmental toxins. The sea level rise is imminent due to the cracking and potential collapse of the Thwaites Glacier, forcing millions of people to become climate refugees, and these are national security risks. And again, 420 parts per million is important because this is the level during the Pliocene era millions of years ago when the oceans were 30 to 80 feet higher. So prevention is more important than ever to prevent the worst effects of climate change. Geoengineering, in my opinion, having looked at the science, is going to be the only way in this small window of time before we hit one of these tipping points. And I've got all of this laid out on the website, www.starseed-revolution.com, and in the book. And it talks about transition to wind, water, solar, getting off fossil fuels, electrifying everything, protecting and restoring 50% of the Earth's lands and ocean, and transforming the food systems through regenerative agriculture apart from geoengineering. We have solutions, but every world government has to come together and every person needs to be educated on this because the window of time is rapidly closing. So Kirkus Reviews did a review of my book when it first came out. This fusion of eco-thriller, new age powered speculative fiction, brutal social commentary, and a bunch of really bad line jokes, by the way, which are in this book, and comedic science fiction a la Douglas Adams offers sagacious solutions to the present day climate crisis, a strange little gem of a tale or an allegorical how-to guide on how to save the planet. Only time will tell. Well, for me, this is my guide to save the planet. It's about, let's have some laugh. Let's learn about solutions at the same period of time. And I want to thank you for your attention. And I now have time for question and answers.
Thank you so much, Dr. Horowitz, for your presentation. I'm going to go first to the chat. We do have one question on here. Can you comment on the efficacy of tetracyclines such as minocycline on persistent babesia?
Minocycline for persistent Klebsiella?
or persistent babesia?
Oh, babesia.
Babesia, yes.
Minocycline, the tetracyclines do not have great effects. I mean, they have some anti-malarial effects. They used to use doxycycline years ago. If you went to India, before Lariam, mefloquine, and tefenequine, and some of these other drugs were around, Malarone, it does have certain anti-malarial effects, but it is nowhere near effective enough to get rid of babesia. Babesia at this point is resistant to all drugs that are out there. It's not to say someone might not get better from Mepron azithromax. Gary Wormser published one case study on tefenequine in someone who was immunodeficient, who got better with tefenequine 3 days in a row, 200 milligrams, and then a pulse of 200 once a week for 6 weeks. We're now starting this trial, but I can tell you, having worked on the HHS committee for babesia, babesia, we need more work. The people at the universities need to be looking at other drug regimens for treating it. Tefenequine is really the only thing I'm looking at right now, because every other regimen, what it does is it knocks down the load of the parasite, but it will not eliminate it completely from the body.
Thank you for addressing that question and for the question that was raised. We have just a comment. Someone provided a good summary tweak of climate change scenarios. We don't have any additional questions in the chat box, so we do have a couple minutes for any questions for Dr. Horowitz. If anybody would like to raise their hand icon or unmute, and Dr. Horowitz, we have time for a couple questions. Just checking to see if anybody has a question. Don't be shy. Now's your time to ask him for a question. Oh, we have a question. Go ahead, Terry.
Hi, thank you for that wonderful presentation. That was great. I feel the more I learn about Lyme and tick-borne diseases, like the more humbled I become, the less I think I know. And as a patient, I find it difficult to navigate through the healthcare system, and we don't quite have the tools that we need to handle it, I feel, appropriately. The one tool that has been mentioned as potentially helpful to me, and I'd actually appreciate your feedback on that, is what are your feelings on the validity of the CD57 test for managing a chronic infection that you can't get access to, or high pulse dapazone that sounds so hopeful? Thank you.
So the problem with CD57 is that it's not specific for Lyme. You can get CD57 in HIV and autoimmune diseases. So, it was published in the medical literature by Ray Stricker as a marker, but one of the things you learn in medical school, and, I did my medical training in Belgium in French, which is why I speak French. One of the things they highlighted in medical school, and it's all medical schools, is that the most important thing you will do in medicine dealing with a patient is taking a proper clinical history. It's not a lab test, ultimately, that tells you whether you still have Lyme disease. It's taking a proper clinical history. So if a patient of mine comes in and they give me, let's say, 10 major symptoms, like the symptoms you saw in the articles I published, you have fatigue, you have headaches, you have migratory joint pain, migratory muscle pain, migratory nerve pain, brain fog, I can't fall asleep, I keep waking up, I have chest pain, palpitations, night sweats, day sweats. Every time a patient comes in, we do these every 4 to 8 weeks, and they're on a regimen, I will go back to those same questions and say, how are those symptoms that you had? If a patient says, after, let's say, double dose dapsone combination therapy, maybe with a pulse of this new high dose dapsone therapy, doc, my fatigue is gone. You're addressing my POTS and adrenal dysfunction made that better. I still have some mild night sweats. You gave me Mepron, azithromax, and clindamycin, and tefenequine, and my sweats are better, but they're not gone. They come, so I know by the history, I knocked down your babesia, but I didn't knock it out. Let's say the symptoms are good for 3.5 weeks out of the year in a woman, but she relapses around her menstrual cycle. When the estrogen levels go down, that's when the Lyme comes out. That would mean to me that I knocked down the load of Borrelia in the body, but there's a little bit left. So it's all a question really of taking a good clinical history and remembering that migratory pain is the hallmark of this disease. So the problem is when you're dealing with symptoms like fatigue, that there can be 1,000 things that cause it, or headaches. These are non-specific symptoms, but when you're dealing with it in the case of a Lyme patient, where there's a gestalt of symptoms that they present with, and you've done a differential diagnosis. And this is where the MSIDS map is so important, because what I find in these people, in navigating the system, you have to make sure you go through those 16 points because most of my patients have low adrenal. If you have low adrenal, you have a low battery. It doesn't matter how well your treatment for Lyme is, you're not going to get better if your adrenals are low. If you have POTS and you have low blood pressure and you keep standing up and you're, get presyncope or syncopal episodes where you're passing out, you're never going to get your fatigue or brain fog or palpitations under control because the issue is not more antibiotics. The issue is basically getting your vagus nerve dysfunction in order. So your doctor has to understand how to do differential diagnosis, go through the 16-point MSIDS map, and they've got to know how to use these persister drug and biofilm agents. Having seen 13,000 patients, I think I got a pretty good handle on this disease. And I am close for the first time in my medical career to finding a durable solution for chronic Lyme patients that if this works, and we have to confirm it in the randomized trial, but it would mean that theoretically 8 weeks of double dose dapsone followed by several pulses of this high dose dapsone will put 2/3 of all chronic Lyme patients in remission with basically 9 or 10 weeks of oral antibiotics, as long as all of the MSIDS variables are taken care of. So what you need to do in Canada for this, because your government, I reviewed your politics and how this has gone, and unfortunately, they adopted some of the IDSA literature on this, which may be fine for acute Lyme, but it's useless for chronic Lyme disease, right? This is medical politics. This is not medical science. If your Canadian government or some people in Canada want to get a university study where you have a clinic and one part of the clinic uses IDSA protocols and another part of the clinic uses ILADS protocols with the MSIDS model and the dapsone, I'll show you this. You can prove this to your government. You can prove it to anyone. The problem is somebody's got to do it, right? I'm confident that you will see the results. So, as far as navigating the system, I understand it's difficult in Canada. And I understand it may not be easy to access all of this, which is unfortunately why some of the Canadian patients have to come to the United States for treatment. But the fact is you got to be going to your MPs and you got to be at their door and knocking on their doors and say, hey, I'm sick. Horowitz and people from ILADS have some answers here. And the government is ignoring all of this. Can you please do some studies? Because the healthcare costs are going to go up. It's a spreading epidemic, right? We know how bad this is. It's only going to get worse over time. You got to raise your voice, folks. That's how they made some of the political changes in the United States. And I'm suggesting you stand up like people are now doing for climate change, like Greta on Fridays for the Future. You got to open your mouth and stand up and get to your MPs and say, this is really unacceptable. There is literature showing Lyme persists. The Canadian government has denied it. There is literature showing that we have protocols that could work in 8-week protocols. Why can't we get access to this in Canada? Open your mouth and speak up. You speak up enough, you'll see that the squeaky wheel is generally the one that ends up getting lubricated.
Thank you, Terry, for your question. We have a couple of questions in the chat box for Dr. Horowitz. The first one is around neutrophils. Can neutrophils penetrate biofilm? Can antibiotics penetrate biofilm? Do we need biofilm busting drugs? Is persistence the problem or is it the biofilm?
So you do need biofilm agents to open the biofilm. As I showed you in the study on dapsone, dapsone alone does have some effect on the biofilm, this resistant biofilm form of Borrelia. By the way, so does rifampin. Rifampin lowers alone as a single drug about 40% of the biofilms. But what we use in our studies is we use essential oils that have been published through Johns Hopkins University, such as cinnamon, clove, oregano oil. These have all been published in the literature. We're now starting to use even peppermint oil. We use biocidin. Biocidin was published through Leona Gilbert in her lab that it is effective on biofilms. We'll use serapeptase. Stevia has been published through Eva Shoppy's lab at the University of New Haven. So our approach is that we use at least 3 different biofilm agents to open up the biofilms when we're doing the antibiotics. Because if you give to someone, I've had patients from other doctors beyond 1 year of IV Rocephin. They come off the Rocephin. They didn't use biofilm agents. They didn't use any persister drugs like dapsone or disulfiram. Within 1 month after coming off a year of Rocephin, they're as sick as they were. I then give them 8 weeks of double dose dapsone and they go into remission for years. So what's wrong with that picture? Did they really need 1 year of IV Rocephin? No, they didn't. What they needed was to open the biofilms and use persister drugs, and Rocephin does not affect the persister forms of Lyme. It only affects the logarithmic, actively growing forms of Borrelia burgdorferi. So when you're looking at Lyme and Borrelia, there are actively growing forms. That's your penicillins and cephalosporins. You have your cystic forms, L forms, S form, round body forms. That's hydroxychloroquine, that's grapefruit seed extract. Then you have your intracellular forms. That's your tetracyclines, rifampin, rifabutin, pyrazinamide, azithromycin or different macrolides, dapsone, right? You need to use intracellular drugs and you've got to use biofilm agents. So after years of doing this, over 30 years, the answer for me, yes, you've got to open up the biofilms. You've got to use these persister drugs. And right now, there's only 2 persister drugs, dapsone and disulfiram. The azlocillin is being looked at from Stanford University, and hygromycin A is being looked at from Kim Lewis's lab, but we don't have any clinical studies on those at this point. The only ones we have clinical studies on is disulfiram and dapsone.
Thank you for the question. You mentioned that a lot of Canadians come across the border for treatment with Lyme and tick-borne. I'm assuming then that Canadians can come and see you if they wish to reach out to your clinic. That was a question.
Yes, we don't, we do have openings. We don't have a lot, but yes, we do have openings. The only problem is, and this is where it gets a little bit tricky, is they've got to load up on antibiotics and all of these agents because it's difficult to get it across the border, right? I mean, I can't ship antibiotics and stuff to Canadian patients, and the Canadian government, right? They only want you to get stuff in Canada. So the difficulty in seeing patients who are international is, unfortunately, a lot of times they need to get stuff in the United States. And that's really a big shame, because you should not have to go outside your healthcare system. I publish every solution I ever find, I publish in the medical literature, right? I mean, I'm not holding into any secrets for myself. I'm sharing it and I'm yelling it from the mountains as loud as I can, so every doctor knows what is working in my clinic. But yes, you can come to my clinic, but even more important for me is get your doctors to be trained in the protocols, like in August when I do the training, and see if you can maybe get some of your universities in Canada to do studies. You can actually enroll, so you don't have to come see me. I'm not looking for business at this time in my career, right? If anything, I'm looking to find the answers and say, hi, come to me, or go to another doctor, get well, and I'll see you once a year, right? So yes, we have room, but I would love your Canadian practitioners to learn these protocols.
Thank you, Dr. Horowitz. One final question I'm going to read off in the chat box to wrap it up, and then I'll let everybody know about tomorrow's presentation. So our last question for today is, do you see correspondence between long COVID and Lyme? Do you see that we need to also look at bringing down the EBV load? And that's the final question for today.
So the randomized controlled trial that I'm waiting to start at the University of California, Irvine, is actually looking at that, because the MSIDS variables that I talked to you about for Lyme, we are looking at those MSID variables in patients who have long COVID. So for example, EBV reactivation is one of the things that has been showing up in long haulers. We will sometimes see HHV6 reactivation or EBV reactivation in Lyme patients. We see mitochondrial dysfunction from free radical oxidative stress in long haulers, because you get this huge amount of inflammation from a cytokine storm. Same problem you see mitochondrial dysfunction in a third of Lyme patients. You see persistence of the virus. They're now showing the virus can hide in certain parts of the body. In Lyme disease, you see that Borrelia can hide under biofilms. In chronic Lyme, you see POTS dysautonomia. In long haulers, a certain percentage is showing up with POTS dysautonomia. So you'll notice there's a lot of overlap in the chronic Lyme and the 16 MSIDS variables with what's been showing up in these long haulers, right? So yes, I mean, I think there is a big overlap when you look at these variables that are showing up. And the fact that now, for example, in Bruce Patterson's lab, when he's using antivirals like Marivoc for CCL5 rantes and pravastatin with ivermectin, he's got a complete protocol for dealing with long COVID. We have treated our long COVID patients, not a lot of them because they come from other practices, but we've treated them with high-dose glutathione and the regimen that is on my website, cangetbetter.com, under the COVID tab. Look at the treatment. We use NAC, high-dose glutathione, and alpha-lipoic acid, curcumin, broccoli seed extract, sulforaphane glucosinolate, and ivermectin 0.2 milligrams per kilo. The ivermectin protocol is highly effective, and there's lots of studies showing ivermectin is effective. That is another example of bad medical politics, because the drug was off-label from Merck, and they wanted to wait to get their drug out. Unfortunately, their drug did not work right. Now we're using Paxlovid, which is about 88% effective. The problem I'm finding with Paxlovid, a couple of the patients who've taken it not only have had gastrointestinal issues with diarrhea, but they've relapsed 14 days afterwards. So I didn't have that problem with ivermectin, treating 130 patients. So unfortunately, it's one more example of medical politics where Big Pharma gets to control the dialogue. I use Big Pharma's drugs, but I got to tell you, unfortunately, the Office of Alternative Medicine of the NIH should have been on top of this from the beginning. We did not have to have 1 million Americans who died from this pandemic because of all this free radical oxidative stress. So I think the MSIDS variables is going to be the answer for long COVID, but I'm not going to know until this randomized trial finally gets done.
Thank you so much, Dr. Horowitz. Again, thank you so much for taking the time today, for presenting, for everybody attending. I just want to draw everybody's attention that we are continuing our Lyme series tomorrow. Dr. Katie Clow, Camille Gio, and Dr. Patrick Layton are presenting on the Canadian Lyme Sentinel Network results from a new surveillance initiative tracking tick-borne disease risk across Canada. That a talk will start at 12 p.m. Eastern Standard Time. Again, a reminder, take part in our challenge, wear green or wear a green face mask, take a photo and share it with us to help spread awareness for Lyme disease. If you want to draw a picture or be creative, send in photos related to your creative art. We also accept those to entries, and all entries received will be automatically entered into a draw of one of 4 $25 Starbucks e-gift cards. And our live draw will take place on our last day of our presentations on May 31st. Send your photos to clydern@gmail.com along with your name and email. Again, thank you so much, Dr. Horowitz, for taking the time today to talk to everybody. Thank you, everybody, for attending. I hope everybody has a great rest of the day, great rest of your week, and hope to catch you tomorrow. Take care.